It's Essential Pittsburgh. I'm Paul Guggenheimer. With the recent assisted suicide of Brittany Maynard in Oregon and renewed conversations on dying with dignity, we wanted to talk about how the conversations on death and dying are changing. If you would like to join our conversation with Dr. Robert Arnold, professor of medicine at the University of Pittsburgh and medical director at UPMC's Palliative and Supportive Institute, let's go to the phones. We have Brian in Penn Township. Brian, welcome to Essential Pittsburgh.
Hey, thanks for taking my call.
You're welcome.
I have kind of a unique perspective in that I, for 8 or 9 years of my career, worked both in hospice and then also in a hospital in intensive care and oncology units. And, I've seen death. I've seen where hospice and palliative care can really provide a good death for someone with lots of dignity and minimal suffering. I've also seen death where, despite the best efforts of hospice and palliative care, people die with a lack of dignity, with pain, with suffering, whether physical or emotional, spiritual. And, having had that experience, I know for me, for my own life, there are certain diagnoses, if I get them, and this is something my family knows, I will choose to end my life on my own terms rather than go to the indignities of dying from certain diseases. And certainly I can do that on my own, but the idea of being able to have that conversation with my physician and that being a clash with the physician to me feels much more compassionate and much more the way it should be done. And so I'm really just calling to speak from my own experience in favor of compassionate assistance for terminally ill, suffering people who want to die.
Dr. Arnold, what about the points that Brian is bringing up here?
So I think that we have pretty good data from Oregon where there's that experience. I think that having that on the table is something that may help and may not help. I think that there are a lot of social questions that need to be answered. So Brian may have a good point. It may be that the social impact decreases it. I think the thing to remember is that even in Oregon, the number of people who ask for aid in dying is very, very small. So as a society, if we're going to spend our time and energy, we ought to focus it on trying to improve the care of all our elderly or all people who have a life-limiting illness rather than focus on the 50 who choose or don't choose assisted suicide.
Let's talk about living wills. How can a living will or advance directives influence a patient's quality of life?
So I think it's hard to talk to people about this issue, and what a living will really does is lets your family know what your values are and what's important if you should get really, really sick. For example, what I hear Brian saying is if I get certain illnesses, don't do anything to make it last longer. If I get a pneumonia, that's a relief. Just make sure that I'm comfortable.